Welcome back, everybody. So I'd like to now introduce our ODP panel discussion. So we're going to follow up with our guests here on stage. With me, I have Jeremy Yale, Lauren House, Rick Smith from ODP. I think most folks in the room know this group, and we thought we would take a little deeper dive into some of the things we talked about a moment or so ago with Deputy Secretary Kristen Ahrens. So I know you guys have a presentation you want to get to, so we'll let you just kind of run with it, and whoever wants to take it on, we'll start there.
Sounds good. Good morning, everyone. Nice to be here. Always nice to be on the west side of the state for a little while. For those of you that I haven't had the opportunity to meet, as Patrick said, my name is Jeremy Yale. I'm the Bureau Director for Policy and Quality Management with the office. I've been with the office for about 4.5 years now, and joined by my two esteemed colleagues. I guess everyone knows the fiscal guy. Why don't we jump right in? So we have a number of areas that we wanted to provide some more meat on the bone from the presentation and discussion that Kristen and Patrick just had. So a few of those things, and certainly not limited if we're able to get through these topics, certainly interested in having more conversation. But we wanted to spend a few minutes on waiver amendments. As we spoke earlier, needs group 5 seems to be a hot topic, so we'll be sure to talk more about that. The supplemental payment changes that are going into effect, some changes coming up with community participation support, in particular, some changes with our variance process. And then we wanted to give this group a very brief update on enterprise case management. And that's code for the new HCSIS. So, all right. So, let's go jump back one more. So we are anticipating our waiver amendments to be in effect November of 23. Those of you that are following along with the bouncing ball, November of 23 aligns with the end of Appendix K. So a few highlights from these amendments, as we talked briefly just a few minutes ago, Specialty Telehealth and Assessment Team, or STAT. Clever, very clever. Assessment, assistive technology and remote supports, equipment and technology. We'll talk a little bit about that. Some changes coming up. Supported employment, again, needs group 5, and some changes, very brief change that we made to music, art, and equine therapy. So the process, and those of you that submitted public comment for waiver amendment, thank you. I know there is a lot of information from the notification of proposed rulemaking that Kristen talked about earlier. There are 2 out there right now, and both of them are 400 pages. So, you know, something to keep next to the nightstand, I suppose. In addition to that, obviously, we have selective contracting out there, which we'll have an opportunity to unpackage a little bit more later on today. And then our public comment for this latest waiver amendment. So it ended the end of June 27th. Many comments, over 500. And just 2 days ago, we were able to submit that to CMS. So we should be in, fingers crossed, pretty good shape for November. So little bit deeper dive. What is STAT? So really the goal and the goal of this is really to have right on time telehealth assessment available to anyone in residential, anyone living in their private home. It will be a service pending budget approval. It will be a service that will be available through all 3 waivers. It is really a service that will be available when physicians are unable to assess a person's medical needs. And one of the thrusts of this service is really to avoid unnecessary emergency room visits. We know that emergency rooms can be dangerous for any one of us, and I think that risk goes up for the population that we care about. So maybe I know, yeah. Why don't you jump in with some other ideas on this?
So we're particularly very excited about STAT for a lot of reasons. First and foremost, right, Jeremy just mentioned just the level of discomfort that any one of us experience sitting in an ED, let alone, right, someone that we're supporting, where that environment is really not the most conducive to them being, successful, let alone well, and that sort of thing. The other thing that this really drives at is, health equity, quite frankly. We know that people with disabilities do not often get the same kind of treatment, medical treatment, in an emergency department for a variety of different reasons, whether it's because they're struggling to communicate, fully what their symptoms are. They are often dismissed because they have a disability. Their behavioral episodes are often dismissed as, just that, rather than a symptom of potentially a psychiatric illness. So we, just are really excited about the fact that we can, start to provide, this service where the expectation is that the vendor here is going to be very highly qualified in terms of supporting people with disabilities, not just, a physician with credentials, which is wonderful, but really someone who has had some additional training and expertise in supporting people who may be experiencing, something medical going on with them. So having that option to have that kind of care, personalized care right away. Certainly, we also know that our hospital systems, our community hospitals, are inundated constantly. People are, kind of using them as their primary care rather than, what they are intended for, which is emergency care. And so anything that we can do, right, sort of collectively, not only as the, IDA system, but, just as DHS as a whole, and wanting our communities to be well and having access to the care that, everybody needs. If we can kind of divert some of that through the use of, really highly qualified, again, medical professionals who can say, this is not necessarily a need for an ED visit. You can, we can prescribe you something. Maybe you need some eye drops, maybe you need some antibiotics, whatever the case is. So whatever we can do, in terms of supporting our communities in that way. And then lastly, really, I think for provider agencies, the thing that's huge here is how many of us as DSPs weren't really sure what to do. And so your default was, I guess I'm taking them to the ER. And then you sat there for ages because it wasn't really a medical emergency. And so because of the nature of a hospital, and the triage system, you're sort of continuing to just sit there and wait. And that contributes to staff burnout. It's, I'm sitting in the ED. I can't leave because I have someone here with me. I need to go pick up my kids from daycare, right? It's the overtime. Now I'm here and someone has to be back at the house with the other folks, right, who we're supporting. So there's lots of other, sort of ripple effects outside of just the great opportunity for clinicians who will have knowledge of those individuals also, to say, this isn't just a random physician. This is someone who's going to have access to this person's medical record, be able to really thoughtfully take a look at all of the things, right, that have been going on with that individual and make a clinical determination of, do I or do I not need to go to the ED today, right? So that's lots of reasons why we're really excited about it. Fingers crossed for the budget, I guess.
So can I ask you, it sounded like you mentioned vendor, and so STAT is going to be, there's a procurement process, or is it somebody that's already doing this service and does have the IDD specialty mastered?
Yeah, it will be an agency or a vendor that is already doing this work. Yeah.
But they will be qualified, right? So they will qualify through sort of the standard PQ process, but as a vendor, right? So which means they will be able to, whatever their published rates are, is what we would adopt and put into an individual's ISP. But, certainly I think lots of providers in this room are currently working with at least one vendor at this point. So you're probably familiar with what those costs kind of look like. And so this is also an opportunity to kind of be able to, bill waiver for that monthly fee that is currently, probably contracted with you all, and put that into the waiver for what we're hearing is pretty nominal amounts of money.
Thank you.
So sure, either after hours, one of the things that we have heard, one of the things that we have heard through the Office of Medical Assistance Programs recently studying home health, there is isolation for medical personnel out in the community, and as Lauren kind of indicated, I think that our staff oftentimes feel isolated in that same way. So it could be unavailable. It could be that I think after hours is probably the best example, or we included unavailable or unable, right? So it might be that the person's primary care is, called and waiting for the doctor to get back, but the situation may now be elevated and they're looking for additional consultation. I think it's a pretty open interpretation. Yeah, thank you.
I think the other thing that we contemplated here was exactly that scenario where typically when you're calling, your primary care doctor, they're not engaging with you in really like a video visit, right? And so they may say, I really can't. And so, right, they are saying kind of either default to the ED or that sort of thing. Whereas this particular service includes that real-time two-way audio and visual, where there is some element of the ability to do some assessment, right? So through a variety of different tools, they're able to take some basic vital signs and that sort of thing. So it is really enhanced to that just kind of cold call to the PCP's office, for example. Yep.
Correct. The question was,
Okay.
this will be available for folks that are living with their families. And yes.
Other questions?
Clarifying question. So how do you access it? Is it like a online? Is it an app or?
So part of the kind of onboarding with an individual, there would be the installation of that two-way video, audio conferencing equipment. Some of the vendors that we have spoken with, they have some specific training for their staff. So there's some acclimation to the person's care plan. I don't know if I answered your question, Marisol.
I guess it's not going to be as like you have to put some thought as a provider a little bit into it to make sure that the people you want to refer to this are already pre-engaged. It sounds like, right?
So it's a good question. I don't know that we have too many preconceived notions around who this will be best for. Again, pending budget, this will be available to any waiver participant. I find it hard, I find it difficult to think of scenarios where this wouldn't make sense for people. But, again, choice, maybe some individuals would not benefit. Maybe many individuals just don't have, more complex health needs and wouldn't necessarily access this service.
And Marisol, I think it's a lot about team discussion. Maybe Michelle, that was sort of where you were thinking too, is, that when the SC is sitting down to have that conversation, it's, checking to be sure that, do you have a way to access this? So do you have a computer that's internet connected, an iPad that's internet connected, that sort of thing? So, right, it does sort of go hand in hand with at least some piece of assistive technology, right? I would consider this, we're trying to get people access to the services that they're looking for. So, right, I think it's about the team planning process too, to be sure that someone can access it and get the best from it. And Michelle.
No, I was just wondering if I seemed that I heard you saying it has to be pre-planned, like, yes, the individual has to already be associated. So it has to be authorized in the plan. It's not just a global service to the staff in the house. Although when I was in direct care, I worked with nurses. I can't imagine like some of those moments if I didn't have this service. So I'm really crossing my fingers on the budget as well, because what a relief to be able to, talk to somebody at midnight and have them let you know, yes, go, yes, ambulance, yes, van, or no, do this, push fluids, you're okay, call me back in 10 minutes. But yeah, it will be in each person's plan.
Thanks, Michelle.
We have another question?
Yeah, just real quick, if I understood the way you described it, you said vendor has to come in and put in two-way video equipment or so. So it's not something that can be done through a smartphone or.
Yeah, I think some of the service models that we've looked at are existing technology.
Oh, okay.
Yeah, it just-
Maybe I misunderstood.
Yeah,
that.
it just has to be video audio, I believe, in most of the scenarios that we've
Okay.
seen.
So when people are out in the community, if something comes up, they can.
Potentially.
Okay, good. Thank you.
Yeah, I know some of the packages also include, and maybe Lauren alluded to this, Bluetooth technology that will, again, give a physician additional vitals, which is pretty cool. All right, so one of the other changes that is going into the waiver relates to assistive technology, and might be difficult to discern there, but the second half of that is bolded, and that's the change. So leasing equipment and devices is only available short-term for these purposes for emergency substitution of a device or equipment until repairs are made or a replacement can be purchased, or to allow a participant to try equipment and devices to determine whether that equipment or device will be a good fit for the person's needs. What we're finding is that leasing of assistive technology over longer periods of time is just not cost effective for the individual, for the state. So really putting this limit in on leasing for assistive technology. To be clear, that is different than our current policy for remote supports. Because of the way that service is delivered, we would anticipate that leasing be part of those plans. Okay, let's keep rolling. So this is a nice enhancement to our enhanced levels of service. The change here for community participation support and in-home and community support, as well as respite, we've added the designation of a therapeutic recreation specialist. So if you have a bachelor's degree or higher in therapeutic rec, that is now eligible for enhanced levels of service. Turn it over to Rick.
Can you hear me? Yeah. Okay. Good morning, everyone. I'm going to talk a little bit about the needs group 5 fee schedule proposal. We are, as you know, we implemented residential fee schedule rates back in 2017. And we have, lots of historical data now since then on exceptional rates. So we engaged and took a look at that data and are proposing to add a new fee schedule group that encompasses the vast majority of existing residential, exceptional rates. So that will save us a lot of time on the administrative side, and hopefully save you guys a lot of time on the administrative side as well. I think when you look at the rates, you'll see that they're quite generous and do encompass most of your existing exceptional rates. That doesn't mean they'll encompass everyone. So there will still be a need for an exceptional rate process. What the way we're proposing to roll it out is that you probably saw as you're developing your 23-24 plans for individuals that had exceptional rates. Those are all going to be end dated as of December 31st. And then anyone who has a current exceptional rate as of that date will then roll into needs group 5 automatically on January 1st. Then going forward, if the needs group 5 rates do not meet individual needs, we'll still have a process to request something in excess of fee schedule. We're going to make that a little more rigorous for our benefit and for your benefit. We're going to require that the individuals who would be eligible for new exceptional rates would have a current HRST. This is, as you know, we've been doing HRST for 3 or 4 years now, and we still have providers who haven't really adopted it, unfortunately. So they'll have to have a current HRST. We're going to have to, as we get further into the calendar year here, I'll have to take a look at existing data and see where that cutoff will be. But in preparation, I think the message is that you should make sure your individuals have a current HRST if they don't already. And then secondarily, we're gonna also look at some historical cost information on folks with exceptional need requests. So what I'm thinking here is that we'll have to, and this is kind of what I already do when you guys go through an appeal process for an exceptional rate. I ask you to provide some historical cost information on what it's costing to serve the individual. So we're going to incorporate that into the process. But we will make that retroactive after you've provided that information and served the individual for a little while. So let me see. And I guess the takeaway is that we're trying to make things easier for you guys and for us, and trying to accommodate what we've learned over the course of the past 5 or 6 years with the fee schedule. Got some good feedback on the break from one of our larger users of the exceptional rate process. So hopefully it works better for everybody. Happy to take some questions on that if you want, or move on.
Sorry, Rick, I know you would love us to move on. I'll start with just one question, and then maybe it'll kick off some while people think about other things they may ask. But needs group 5, is it really just for those with needs exception rates right now? Or is needs group 5 going to be defined as something that people qualify for? There's a needs group 5, like right now in how it was published, the crosswalks to the CIS levels are evident for the other needs groups. But for needs group 5, it simply says per ODP policy. So just wondering how people will become authorized, even if they're not currently receiving a needs exception rate.
Yeah. So the way, and still more work to do on this. So that's why it says per ODP policy, because we want to look at the best data we can to determine what that policy should be. But the way we're envisioning, at least for January start, is that it will be existing exceptional rates will automatically roll into needs group 5. How people come into needs group 5, I think it'll probably be a combination of, I have a person who is in needs group 4 and has a need for an exceptional rate. Then we'll take a look at them, promote them to needs group 5, assuming they have the HRST level indicated.
Okay.
So it's not fully defined yet, but that's just generally how I'm
Okay,
thinking
sure.
about
We'll
it. So
certainly give you that. That's still under development, but it sounds like there would be a request to be in needs group 5, not that automatically it would be a defined service level that certain people would be assessed and qualified to go into.
that's the way I'm currently thinking about it. Correct.
Okay, other questions on anything really? And I don't know if this is a good time. You mentioned enterprise case management, and I know ODP is hosting a work group in the MSA auditorium across the hall that'll begin shortly after the lunch hour begins. So we've had some members sign up for that. We're looking for providers only to contribute on that. And We got a couple of people who signed up that couldn't make it. So if you're interested in signing on to that, we have a little bit of space. No, I just wanted to
Okay.
jump in. Please, I hope you do.
So no needs group 5 questions, right? Excellent.
They're being so nice to you.
I know, this is good. Oh,
I'll jump back in here. So one of the things that we heard pretty clearly through public comment is that providers and individuals alike enjoy this benefit, enjoy this part of the waiver, music, art, and equine therapy. But one of the things that we heard was that oftentimes these are delivered in groups, and our current rate structure is by individual. So what we've simply done was, in addition to individuals, we've added group therapies for no more than 4 individuals. So we feeling pretty good about that. It was an easy one for an easy change for us to make. And again, the process works, right? Public comment process works. You're back up.
back to me. As Kristen alluded to in her presentation, so we very much are appreciative of the ARPA supplemental funding from the federal government, and had when we first proposed these payments, had looked at utilization and how the recovery was going, and had made some certain assumptions about where it was going and what providers would be able to do. So as she mentioned, as in response to public comment and analyzing the current data on how the recovery is going, in order to spend all the available funding, we had to expand the categories a bit on CPS. So I think, I don't recall off the top of my head, but previously it went from 100 to 75% maybe, and I think we lowered it. We took it all the way down to anybody who's providing CPS now, and also increased the amount per individual. So we're expecting, based on the May data, anyways, that this will allow us to utilize all of the available funding for CPS recovery. Also, when you see the announcement, you'll see that there's a simpler way to do it. We had initially proposed looking at a smaller period, couple months right before the pandemic, and then a month after 6/30. So now we're just looking at how many people did you serve during fiscal year 1920? How many people did you serve in CPS during fiscal 22-23? Just comparing those two numbers to that'll make my life easier and your life easier. So as she mentioned, we have to get approval from CMS on this first. So I would guess payments will probably happen towards the later part of the calendar year. And there will be, I don't know if you guys probably recall, early on in the pandemic, we sent out Act 24 funds, which we just sent to all providers and didn't ask, you didn't have to ask for them. But for these supplemental payments for CPS and supported employment and supports coordination, there will be a request, a very simple request form where you just have to, email me and say, yes, we want these payments. So we don't have to go through the hassle of providers getting money they don't know what it's for. So that should be coming out in the not too distant future. I'm expecting in the next week or two. So I think that's good news. So that in our ARPA plan, we had allocated $40 million for these this category of supplemental payments, and I think we'll be able to get there, assuming you guys want the money. So.
I see smiling faces out there, Rick. So it was an easy one to deliver. As Rick said, right, we don't want to leave any money on the table with the Fed. We want to be able to encumber all of these ARPA dollars. And as the Deputy Secretary said this morning, we want to make sure that we use all of our resources in directing towards recovery of CPS. So.
And Rick and Jeremy, will that pretty much cover the allocation under ARPA? With these adjustments do you anticipate having some surplus funds that would go elsewhere? I think that's been extended yet. The state has until March of 2025, I believe, to use everything. Will this pretty much take care of what you intend to spend or what you were allocated?
So again, we have, I think, in total 18. So I don't know where that sits in total. But certainly for what we had allocated for this particular initiative. What was the other part of your question?
I don't remember.
It was well worded though.
So I'll move on to my next question if I haven't forgotten that yet, which I have. Back to you.
Great, thank you.
Yeah, I was actually going to ask about, it seems that there was some suggestion that maybe on some of the earlier initiatives, there would be the possibility of cost reporting. And Rick, you mentioned Act 24, and I can't even remember, it may have even been Act 24, but just wanted to circle back. It doesn't appear that there's ever been a request for how funds were spent on, say, recruitment and retention. Is there going to be any need for reporting on it, on any of the initiatives?
At this point, I'm not anticipating any need or expecting any need for reporting on the use of the funds. I would caution, as these are all supplemental payments, they're subject to claims review through our normal QA&I process. So you should definitely
track.
keep documentation on how you use the money in case you are sampled and asked to provide documentation. So
Yep. Thanks, Rick.
I got this one. So one of the next changes that we wanted to cover for the November waiver amendments is something that we're also very excited about. But as you all know, for a very long time, you've been doing in CPS programs individual variance forms where folks are not spending 25% or more of their time out in the community. And so what we have heard through interactions with provider agencies rendering CPS was, can we look at this, kind of more holistically? And so we are removing the individual variance process in favor of doing just that. And so what you see on the screen is sort of the condensed version of very lengthy kind of not so much instructions, but really some guidance that everybody should already be familiar with in terms of quality management. But what we'll be expecting is for all of the service locations that are rendering CPS with more than 10% of those individuals spending less than 25% of their time in the community would be required to effectively add a specific initiative around increasing community participation and embed that in your quality management plan. And again, the quality management plan standards remain the same here. I think what we did was kind of give a little nudge with the language in terms of these are the things to sort of focus on and highlight and document in terms of your efforts to really create, meaningful opportunities for folks to really get out in the community. And so rather than that sort of one-off, more of a, rote process of doing that variance every year and, having supports coordination help you facilitate that. We're looking to say, as an organization, where are we going? How are we creating these opportunities for folks to really get embedded in their communities in ways that they actually care about, and making sure that we're offering those opportunities for everyone that we're supporting.
So having had the opportunity to be part of quality councils and certainly the Isaac, one of the things is at the end of the day, there's really certainly quality management plans can be creative, but at the end of the day, really there's a few good ways to go about something, right? So I would just suggest like leaning into Patrick and your association to facilitate some conversations around this. Facilitate those good ideas that you have within your organizations and share those good ideas. Again, we're striving towards approval of that settings rule plan. So.
Sure. Oh, yeah, go ahead.
So in a case where you're getting them out in the community, but you're not calling it CPS community, they're going out and doing small group activities, or they're going out and doing supported employment, they're working in the community, we'll be able to count that then. So in other words, somebody who used to go to the facility 5 days a week and now going to the facility, and in that 6-hour time period, maybe 2 of those hours are spent out in the community doing recycling and small group activity. Because part of the problem we ran into and why we had to, we created things beyond that facility community piece was that we have older clients whose families and themselves are dependent upon making money. So they would say, well, no, we'll sign the variance because we want to make money, but we wanted to honor getting them in the community. So maybe they're going and working at the food pantry. So they're getting paid, they're making money. So we're satisfying that. But of course, we weren't able to count it because they weren't going out CPS community. It might have been small group. It might have been supported employment. They might have gone to work at the hardware store. So we'll be able to count it with them as being out in the community.
Right. So I think if I'm hearing your question accurately, really it comes down to the way that your it's the only metric, right, is not facility versus community, right? It's how do you incorporate those other periods of time where someone is in the community? And so, yeah, I think we need to think, have providers think about ways that you can demonstrate, right, that it might not have necessarily been that true procedure code, but, the option for the, someone's employed. Yeah, we need to be able to figure out how to incorporate those different pieces of data rather than, strictly looking at it from, procedure to, those designated procedure codes. Yeah.
Susan, I think you hit the spirit of what we're trying to accomplish. There we could have some fine adjustments there though, but you're certainly talking about the spirit, right? The idea is to get people doing the things that they choose to do and enjoy in the community. So thank you for your efforts. Yeah.
It was crazy. So being able, and this is doing it in a much more choice. This is really about the individual's choice. This is what they want to be doing. And so you're allowing us to honor choice and yet not get slapped on the wrist because we were sending them out in the community, but we couldn't take credit for it.
Yeah, absolutely.
I like everything you said except slap on the wrist. I don't know that we ever were penalizing. That's right. That's right.
Yes. Yeah. You want me to do this one? All right. So I did want to talk a little bit about ECM today. As Patrick mentioned earlier, we'll be doing a little bit of a kind of working session over lunch with a handful of folks. But we are, of course, really excited about the ECM project, known as the Hicks's replacement. Finally, does seem like we've been working on this for ages. I'm sure many of you also sat in the initial user story sessions. It feels like, forever ago that we did that. And so we are finally at a place where we're, taking those user stories and starting to really start to translate those for, what will eventually become ECM. So you see on the screen here, we've got our vendors finally in place. The platform is called PEGA. The system integrator is Accenture. And just a couple of quick details about these two specific vendors that really made us very excited at the recent kickoff is that they have worked together for about 10 years on a variety of different projects, national projects, really, things like Social Security Administration and all that kind of stuff. And Kristen has talked about this in other settings as well. But the thing that really gave us some sense of security in these folks know what they're doing is the fact that they manage all the air traffic control for Heathrow Airport. And so if they can manage that, I hope that they can also manage the very complicated system that we have kind of laid in their laps to help us develop. So we're very excited about the kickoff. Really, we are truly full steam ahead at this point with ECM.
Some of the really cool bells and whistles that we're just starting to learn more about, things like artificial intelligence built into it. The platform is low code. So one of the things that was a barrier for the department with Pixis is that it was custom. Everything that was programmed was really a custom build. This is a standard platform with low code. So we're anticipating that as our business collective, our collective business needs change over time, we will have a better opportunity to build that into this platform. So, we're again with the idea of just user or dreaming this up here, as we have access to artificial intelligence running standard in the background, right? We could perhaps start to look for keywords in case notes and start to tease out things that maybe human beings aren't really great at, but machines working behind the scenes can really help us to have a deeper understanding of the people that we care about and are trying to coordinate services for. So stay tuned.
Yeah, lots of great opportunities for us, I think, in ECM. One of the other things to kind of call out is that these two vendors working together really also do well in terms of sort of mapping and planning of like procedural workflows, right? So, you do these things in a particular order. The other thing, that's happening in the background is that machine learning. And so it's learning, your most routine sort of things that you're doing and interacting with in the system. So it really does have an incredible opportunity to make all of the work that we're doing so much more efficient. One of the things that we hear, like, complaints about Hixis and even ECM or EIM at times is, the number of clicks that it takes. And so if it can start to anticipate where I'm going to go, right? It's like the same thing that happens with the phones in our pockets. You get in the car in the morning and it knows, are you heading to Costco because it's Sunday morning? Yes, I am. Please map me there, right? So it's that sort of thing that we're going to have access to in this system. So lots of stuff to be excited about.
Gonna say that I hope you guys are all excited about this too, because it should make your lives easier as well. Not having to enter information at 10 different places for a person's record, being able to find what you're looking for in the ISP. I mean, it's really a flexible design and user-friendly design. So hopefully you guys are as excited as we are for this. Better access to data, better access to information. So yeah.
Yeah, sort of built-in data analytic opportunities. And to Rick's point, right, we know right now providers don't have great access and control over, right, things like the plan and that sort of thing. And so certainly we'll dig in a little bit more over the working session. But that's exactly what we want to talk to you about is, if we, kind of envision providers having better and improved access to things like the plan and, being able to upload notes and that sort of thing, what does that look like? And what's the best functionality for us to put forth, to the vendors and be able to best describe so that we get it right, right? So timeline, this really is just informational purposes. Of course, things can kind of get bumped around depending on how things go, but we are at a place now where beginning in terms of what offices are going to go first. We'll see BHA, so hearings and appeals, they'll go first. And then we're following shortly after that. And so the way that the design process has been structured is that we will have opportunities with subject matter experts and others in the office who will, help to make these decisions, get folks together, work on those design sessions in sort of a very condensed time period, start that testing, and then we can kind of go back and revise where, we think things need to be updated and that sort of thing. But it's kind of a general timeframe. So I think we're looking more at like a 2025 for you all to see some early functionality with ECM.
And here's just an embedded link to some information if you're looking for some additional information out on the Department of Human Services website. I think that rounds us out.
Well, thank you. That sounds really great. So we have a few moments for some questions from anyone.
The ECM project is really exciting. I was just curious if there's going to be any consideration given to simplifying the ISP document along with that process so that you're building a new document into a new system.
Yeah, that's a great question. And thanks for bringing that up. So we have, of course, while, we won't see some of those early functionality pieces of ECM for a little while still, we have been working internally at ODP on some design ideas because, right, we want to be prepared for when it's time for us to sit in the room with those vendors. We want to know what we want, right, in advance. And so we've been working probably about a year, almost a year at this point, on basically redesigning the ISP. And that, that really was first and foremost what we wanted to take on to make sure that we we capture the right information, that it really is the spirit of walking from someone through really where are they now and where do they want to be in the future, in terms of their interaction with the service system, what's the service system intending really to do for them and by way of supports. We are really leaning very heavily into life course and sort of the framework of charting the life course to do this work. So you'll see all of that from the way that supports coordination even initially starts to interact with folks, really specific questions and prompts based on a person's age, right? So their life stage, and then also in different areas of life. So adopting that, like the life domains, if you're familiar with charting the life course. So, asking very specific questions around employment for someone who's working age. Maybe we're not asking those employment questions for someone who's, birth to 3, for example. So it really, again, because of that the intelligence behind, what's driving it, it'll know, this is this person's date of birth. So this is how old they are. These are the questions that the SC will be prompted to be asking, right, of individuals and families. So we really have done a lot of work to make sure that the ISP will really be thoughtfully designed, and again, really heavily focus on the goals of why are you getting this service, and are you achieving those goals, and having that software to be able to help us measure those things.
One of the other design elements that we're working on is an individual and family portal, and so as Lauren mentioned, using the life course as a backbone to that, being able to give individuals more freedom and flexibility to engage and use that framework, collect information, and then successfully pull that into the ISP. Again, trying to avoid duplication of effort and trying to really design this in intelligent ways.
Jeremy, Lauren, Rick, thank you very much. We know you'll be back for our next session, so I think we'll give everybody a short break.